Before this, I have some history about schizophrenia. All of us, we know different treatment modalities before discovering the treatment, like artificial hibernation, insulin coma, frontal lobotomy, and what happened before the introduction of chlorpromazine. When chlorpromazine came, it is called large actile, which is large acting drugs. And these drugs, when discovered, it is discovered as a drug used in anesthesia and used by Daly and Daniker for the treatment of schizophrenia. And they introduced a paper for the first time, 1952, that this drug can help us to alleviate hallucination and delusion within 3 days. Okay? And this has happened 1952. And in 1963, they discovered the cause of the mechanism of action of this drug. It is due to antidopaminergic action. And from this time, this is the Nobel Prize, second Nobel Prize of Arvid Carlsson, who he's the father of the dopamine and discovered that it is the mechanism of action of the antipsychotic. So when we get to the first patient in the first episode, we have to know that why it is important from the first episode to treat the patient effectively. We have many concepts about this idea. Number one, if you are not treating the patient effectively, the psychotic symptoms is toxic to the brain, and the patient outcome will be poor. So the patient has to treat it effectively, and we have to diminish the duration of untreated psychosis. Number two, if the patient is not treated effectively, the percent of suicide will increase, incarceration, comorbid conditions will come. So it is important to treat the patient effectively. And this is a story of treatment duration of untreated psychosis. So we have to choose from the first episode the effective treatment for the patient. And we have two philosophy. One is optimistic, that we can reverse what happened in the schizophrenia if we treat early by the effective treatment. And the second philosophy, which is pessimistic, what happened, we can't reverse it at all in case of schizophrenia. Try to take the optimistic attitude and go on. Second point in the treatment of the first episode is the early onset of action of antipsychotic. From day one, Daly and Daniker observed that chlorpromazine is effective from the third day. But we have another concept that antipsychotic, it is like antidepressant, it needs 2 to 3 weeks to be effective. But actually, in the meta-analysis, we found the antipsychotic, which is acting on the dopaminergic receptors, is effective from the first week, first 4 days. Why the effect of the antipsychotic is delayed? So we have paradox. Despite that the antipsychotic effect out of blocking the dopaminergic receptor has to work within 3 days or 4 days. Why we are thinking that there is delaying in the action? This is a meta-analysis which proved that if you are treating patient with the antipsychotic, from the first week, the condition is improving. And if you thought that this is the placebo effect, we remove the placebo effect and the results are the same. And if you think that the results are coming from the sedation, sedative effect of the drug, out of decreasing anxiety and depression, and not the core symptoms of schizophrenia, we removed all these associated symptoms, and the core psychotic symptoms proved to be diminished from the first week of treatment with the antipsychotic. So we have to see the effect of the antipsychotic within 1 week. And if you find a response, you can say at this time, time is a drug. So you will improve more and more if you continue in the same treatment as you see in this picture. But if you didn't find the treatment, time is not a drug. Time is a toxic to the patient. So you have to change the drug out of this theory. So early onset of schizophrenia, if you are treating the patient, probably the patient will improve. And if the patient is not responding, what to do? This is one of the treatment like zebrazidone injection. We give the zebrazidone by low doses, which is not effective, and zebrazidone in high doses, it is so effective from day one. And also when we repeat the study with olanzapine and haloperidol, it is effective from the first 24 hours. So why, if the patient is not responding, why we are waiting? We are waiting because there is an assumption in our head that the treatment is delayed, or the response is delayed in the case of the antipsychotic. But they found the same story with quetiapine from the first week, aripiprazole, zebrazidone. And there is another study proved that if you didn't give a response and you are wait, the response will not come. And if you get a response and you wait, the response will be improving more and more. So why you are waiting? And this is replicated in another study. So if the patient is not responding, what is our strategy facing these cases? Our strategy is polypharmacy, adding antipsychotic to each other, or switching, or increase the duration, as we heard that time is a drug, or increase the dose, and lastly is clozapine. So clozapine come lastly, and we know that if clozapine came lastly, it will not be as effective, or the outcome will be not as effective if we introduce clozapine very early. This is the philosophy of polypharmacy. We added first generation to first generation to second generation in comparison to first generation. And if we shift first generation to second generation in comparison to second generation, all of this combination in polypharmacy philosophy added side effect, and there is no effect. And this is a side effect: weight gain, metabolic syndrome, drug-drug interaction, cost is increased. So it is better, and also the story comes to switch, increase the dose, or increase the duration. So we have to come to the guidelines or the algorithm. The guidelines is starting with one of the second generation antipsychotic, no response, increase the dose till 3 months. If the patient is not responding, we shift to the second antipsychotic. And thirdly, if the patient is not responding, we shift to clozapine. This is our algorithm or guidelines teach us. But try to think what we found in these guidelines. We found if you start with the trial, number 1, and all of us is starting with olanzapine and risperidone. If you start with olanzapine and risperidone, we'll get 75% response. In the second, and that other 25%, if you repeat, change the drug, the patient is taking olanzapine, then taking risperidone, you will find 16%. Try to imagine if you start clozapine, it will be 75% in the third trial. Try to shift the clozapine to the second trial. You get how much is the response of this patient. And if we know that, if you start with olanzapine and you are shifting to risperidone in the second trial, you will get only 5% improvement. But if you are starting with risperidone and shift to olanzapine, you will get 26. So try to think, if you are starting with olanzapine and you didn't get improvement, try to think about clozapine in the third trial as early as possible, because the response is weak. And this is the story that the patient is taking olanzapine for the first 3 months and then shift to risperidone. and the patient is not responding. When you are shifting to clozapine, the response is marvelous, and the patient non-responding and refusing to take clozapine started to continue on the same non-response and in the same resistance. So in trial 1 and the trial 2, you are treating some patients, but the residual patient, which is treatment-resistant patient in trial 3 with clozapine, the percent is 75. But we have 25% is ultra-resistant because they are resistant to clozapine. How we can do with this patient? This is a question to Dr. Christophe. How we can do for this ultra-treatment-resistant patient? And this is the story of the treatment-resistant patient, the physiology of the treatment-resistant patient. In the striatum, the classic theory of schizophrenia that the dopamine is over-released, is increasing release of the dopamine. In which area? It is not from the mesolimbic area. It is from the associative striatum area. The striatum nowadays is the area is responsible for the psychosis, not the mesolimbic area, which we thought before. So if you thought that patient is normal, and this is the dopamine release in this patient in the striatum, if the patient gets schizophrenia and took antipsychotic, antidopaminergic drug, and you measure the dopamine in the striatum, it is high. So the antidopaminergic is so effective. But if you took a sample from the patient resistant to antipsychotic, regular D2 antipsychotic, we will find that the dopamine release is normal. So why you are using antidopaminergic in a patient, there is no release, more release of the dopamine. So we have two types of psychosis, dopaminergic psychosis and the non-dopaminergic psychosis. Dopaminergic psychosis is responding to the antipsychotic D2. And the non-dopaminergic psychosis, we have to think about another drug from day one, but we have to follow the guidelines because there is rules to use the clozapine for non-dopaminergic psychosis. So this is the three types of treatment-resistant schizophrenia, and this is the primary non-dopaminergic psychosis, and there is another type of psychosis. So my message is, from the first episode, schizophrenia, if you find the patient is not responding, this is non-dopaminergic psychosis. Prepare yourself from the first episode after 2 trials of the antipsychotic, and the patient proved to be resistant to introduce clozapine. We find a lot of patients revolving between clinics and taking antipsychotic and polypharmacy and drugs over drugs and taking side effect, and we are hesitant to use the clozapine. And thank you.